I'm Dr. Nazir Qadri, and here with my co-chair, Munir al-Zakka, and Dr. Natalia Al-Shawabke. We're all electrophysiologists, and it is my pleasure to introduce Dr. Mohammad Al-Hajjiri. He is an interventional cardiac electrophysiologist, and he's proud of it. He's a hard worker on it, and he's going to talk to us about atrial fibrillation from A to W.
That's right. We're not A to Z yet.
And I'm extremely interested to hear what he is going to say. Atrial fibrillation is one of the major and most
common
electrophysiologic problem. And actually, it has lots of morbidity. So good therapy will be a great thing. Okay?
Thank you very much. Thank you all. Thank you all for inviting me. Now, what is an electrophysiologist doing in an interventional conference? Well, I'm here to talk about AFib, but from your standpoint. So we're not, which is the interventional cardiologist, the general cardiologist, the internal medicine, and the interest in atrial fibrillation. You are all going to see AFib. You all see and treat AFib. But it's my job just maybe give you a little bit of perspective from an EP. So we're going to do this in a case-based pattern because it's more interesting. We have this 32-year-old man with palpitations, came to the ER, and obviously he's in AFib. The next step, and this is something we usually ask questions. Do we cardiovert right away? Do we do amiodarone, Concor, and Eliquis? Do we do IV heparin, TEE cardioversion next morning, or TEE cardioversion right away? Now, for the interest of time, we probably don't have much, we can't really use much clickers. One of the things, people who work with me know that I actually hate amiodarone so much. So, and I really don't like to use it. For this patient, IV heparin TEE DCCV is probably the most appropriate action of care. We're going to talk about this, the outline, the cases, and we're going to go in this. And that's what we actually did, TEE cardioversion. We gave some heparin, and make sure whenever a patient with atrial fibrillation comes to you, we should never ever cardiovert because we cannot trust what patients tell us. They may tell us, oh, just started. But the truth is when they start feeling it, this is the time when it's in RVR. It's not always the onset of AFib. It is not always reliable. And this means that if we cardiovert without TEE, or we give cordarone or amiodarone without TEE, we risk a stroke. So the same patient came back with AFib a month later. Now, we can do flecainide, amiodarone, digoxin, or amlodipine. Obviously, amlodipine is going to be useless here. Amiodarone is a big no-no. This guy is only 34 years, in the 30s, so you don't want to give it. Flecainide is actually very reasonable. Digoxin is not a very reasonable medication. So flecainide might be a good medication. Now, what if it's back? And people who work with AFib know that AFib keeps coming back. It's the most annoying thing in the world. So it is very reasonable to start flecainide as long as the patient does not have any coronary artery disease and no structural abnormalities, and as long as that the patient's ejection fraction is normal. So the next step, if it's back again, would you give amiodarone now, dronedarone, Concor, or we do an ablation? So I would choose an ablation, obviously. And it would be an ablation. Let me just, for the interventional cardiologist and for you guys, let's just simplify this a little bit. So this is a left atrium. The atrial fibrillation comes from left atrium, as you guys all know, and the purple color is normal tissue. The red color are the veins where atrial fibrillation comes from. So this patient, it is very healthy because it is all, the color is purple. So when you see purple color, it means the tissue is healthy. This is a three-dimensional map. This is how we draw the left atrium in the EP lab. When we draw it, it gives us colors. And this patient has a healthy left atrium. And this means when they have a healthy left atrium, means that the ablation success rate has the highest potential. So it's around 88%, which is the highest. So this is the three-dimensional map. The left atrium looks nice and pretty, and this is a great time to do an ablation for the atrial fibrillation. Those little spots that you see are the places where I ablated, and you isolate the pulmonary veins because this is where atrial fibrillation comes from. Okay, so let's see another patient, 65-year-old woman who has paroxysmal AFib, ejection fraction is low, negative ischemic workup, and we have normal valves. This is a full ablation. So, and we'll talk about why we jumped into the ablation. You're going to find it very quick, but when you see, this is the catheter, the yellow catheter is myself, and now we are drawing, and now you're going to find that, if we can just pause this, there. You're going to find in here there's a lot more red. So there's a lot, it just means there's a lot more, when you have more red, it just means the tissue is destroyed and there's a lot worse outcomes, which means, so if you compare this one to the previous one, I know this is there. So you have a lot more green, and I think it's repeating itself. Okay, so we'll find another one. A 42-year-old with MVR, 10 years of AFib, failed antiarrhythmic. What would you do? Amio, or flecainide. Well, you're going to do ablation. Let's look at this one. Now compare the previous ones that I showed you, which has a lot of purple, with this one. This one, it is all destroyed tissue. So the tissue that you can see here, it is all red and green and all of that stuff. So this is the left atrium, but all this color that you see is destroyed left atrial tissue. This is from the atrial fibrillation. You don't want your patient to reach to this point. So the guidelines have changed, and we'll go over this shortly. It is no longer the case where you wait on AFib and you do not ablate. We no longer go by the AFFIRM trial, which is from 2003. The AFFIRM trial historically was our base where we go and where it compared rhythm control with rate control and found no difference. But it is true, but that's because this technology did not exist at that time. So you don't want your patient to get to this point. Ablation right now is a class 1 indication. As you can see, there's so much destroyed tissue in the left atrium. This is the right atrium with equally destroyed tissue. So, and we ended up ablating. So the 2023 ACC guidelines, the update to the guidelines, made it catheter ablation of atrial fibrillation receives a class 1 indication as first-line therapy in selected patients. So ablation is a safe method right now. We no longer go by the previous guidelines, which showed that there's no difference between rate control and rhythm control. This is no longer the case, especially in paroxysmal atrial fibrillation when we are still in, when the atrium is still not damaged. Early rhythm control, the importance of early and continued management of patient AFib should focus on maintaining sinus rhythm and minimizing AFib burden. Sinus rhythm reduces strokes, sinus rhythm reduces heart failure, and sinus rhythm reduces symptoms. There's a recent study that was about a year ago that showed patients with untreated atrial fibrillation have an 18% risk of committing suicide. So it's that bad. Catheter ablation of AF in appropriate patients with heart failure and reduced ejection fraction receives a class 1 indication. So the patient we talked about where her ejection fraction was low, we have to have a fib ablation. You have to maintain sinus rhythm, otherwise the heart failure is not going to get better. We have different definitions of AFib, and for the interest of time, we're not going to go over them. We no longer have lone AFib. That's no longer a definition. So if you have an AFib, it's a spectrum of AFib. You're either at the beginning of the spectrum or at the end of the spectrum. We're seeing a lot of AFib right now because of COVID. COVID has increased significantly AFib. COVID can cause AFib, PVCs, and heart failure. Okay. So this is a quick, for the interest of time, we're not going to go over it. No structural heart disease. Medical therapy is very important. So everything is a class. is a first-line treatment except for amiodarone. Amiodarone is not a first-line treatment. So dofetilide, dronedarone, flecainide, propafenone, and sotalol. Unfortunately, none of these medications are available in Jordan. So that's why everybody in a way, feels forced to give amiodarone. With structural heart disease, with CAD, make sure you do not give flecainide with coronary artery disease because you could kill the patient. But it is okay to go for catheter ablation from the onset. It's no longer the case. So let's see this one. This is a 55-year-old with 10 years of atrial fibrillation. And then you can see the damage in the atrium. If you remember the very first model I showed you, that was all purple. But look at the atrium here. It is completely damaged. There's so much fibrous tissue. There's so much scar tissue. The success rate for this patient is not going to be the nice 85 or 88%. The success rate for this patient is probably going to be around 70% or even maybe worse if it's persistent. Let's go to the next slide. Regular follow-up, ablations work so far. Whenever we do the ablation, we have to follow up. Sometimes when you are in persistent stage, you want an antiarrhythmic in addition to the ablation. Ablation alone may not be sufficient for these patients. This is a 45-year-old patient with so much destruction, and also the same thing. Unfortunately, we see a lot of patients in Jordan because most of them have gone to the chronic persistent phase, and the cost of ablation is a big thing. This is a patient who's had breast cancer and AFib, multiple AFib episodes, and you can see, patients got better. Right now, in the guidelines, patients with cancer can also undergo an ablation. Okay, this is a 26-year-old female with AFib, the same thing. You can see this is after COVID. Okay. So we talked about the ablation. We went over the guidelines very quickly. And now what do? Why is it AFib from A to W? It's from ablation to Watchman. Because Watchman right now is the groundbreaking new technology that is used to stop the blood thinners. This is a patient who was 87 years old, and we just implanted the Watchman in him just a couple months ago. And as you can see here, this is deploying the Watchman, and there it is. This is in the left atrial appendage. This is another patient who was 83 years old, who's had a TAVI, a left bundle pacemaker, and then we ended up putting an amulet in him. So this guy has a very interesting lifestyle. He lives between here and Barcelona, and he did not want to be on any medications. So he's kind of a bionic because he has a TAVI, left bundle, and an amulet. So left atrial appendage occlusion devices, there's the Watchman and there's the amulet. This is we've been implanting the Watchman since 2000. I think the first one was 2014. The first one I implanted was 2016. And recently, there it is. So what it is just a plug. You just put the plug in the left atrial appendage. That's all it is. It's very easy. It's a half an hour to an hour procedure. It's a catheter. You just do the transeptal. You go to the left atrium, and you put it in. We're very lucky that we recently started having Watchman Flex available in Jordan, and I implanted around 5 of those in the last month or so. The left side is the Watchman, the right side is the amulet, and as you can see, the amulet has the disc. There was a comparison, there's a meta-analysis that compared both Watchman and amulet, and actually showed the Watchman is superior, 98.5% success rate, and when I say by that, that means it doesn't develop a clot on it, whereas the amulet is around 96%. But they're still both are actually very valuable technologies. But the Watchman is very interesting because it's actually very safe. It's the safest device. It's 0.5% major adverse events, 0.5% ischemic strokes, 0% all-cause death, 0% pericardial effusions. That's because the way this technology works, and 0% device embolization. And this is very interesting because compared to the old Watchman, this data was definitely not like that. There was device embolization, there were all these also pericardial effusions, but the way this works is because it blocks the left atrium in this way. Even with effusions, it's actually very safe. Left atrial occlusion device data, this is all data for the Watchman Flex, and the Watchman Flex, as you can see, it is superior in everything in comparison to the amulet. The Watchman Flex, 100% of patients have effective left atrial appendage closure at 12 months. So you close the left atrial appendage completely, and then you stop taking the blood thinners. Different ways when you put the Watchman Flex is no longer like the Watchman, so you can stop the anticoagulation right away, right after the implantation. You can stop it, and you can start aspirin Plavix, and you can stop one of them 2 months later. Right now, we are all heading towards single antiplatelet therapy, which means just aspirin. You put the Watchman, and you just put them on an aspirin or Plavix. So bottom line is, the last 40 seconds, ablations work. The guidelines have changed, so we no longer go by that very old trial, which showed that there was no difference between rate control and rhythm control. There is a difference with all these newer trials. Reduce the trial of antiarrhythmic drugs, and then ablation is a class 1. It's fine. Remember, we can get flecainide is a great medication, but unfortunately, it's very difficult to have in Jordan. And then finally, reduce the use of amiodarone. Amio has a lot of issues. And then ablate early. Don't wait until the scar tissue and remodeling starts. Thank you very much.
Thank you. Very prompt. Thank you.
Thank you.
I have a question.
Yes.
There are patients, as you said, UTA 3, UTA 4, loss of fibrosis, and
Yes.
The success rate is low. What do you think about PACE and ablate?
So
Ablate and PACE for those patients.
it's a reasonable thing. Personally, I would only do, like back in the US, some of my colleagues would ablate like 5 times, and they would keep doing it. But I think that's kind of crazy. So right now, I think pacemaker and AV node ablation is reasonable, especially in elderly patients. However, there was a recent retrospective study that showed increase in mortality in patients where you go for AV node ablation with an AV node ablation with a pacemaker. So currently, what I would do is a left bundle pacemaker or a CRTP. I think that's more reasonable, and then you can ablate. And there's always the risk, because once you ablate the AV node, there's always the risk of detrimental RV pacing, which is around a third of patients. Very high. It's 30% when you're RV pacing all the time.
Exactly what I meant by V pacing.
Yeah, exactly.
Or left bundle pacing. Any questions? No. Okay.
Thanks, Mohammad, for the nice lecture.
Thank you.
So a take-home message for general cardiologists when the patient comes to the ER with atrial fibrillation: one, do not depend on the onset. So the story about less than 40 hours, go ahead and DC shock him, that is, now it should be out.
Well, because patients are unreliable.
I agree, but it should be out. So this
Correct.
is one of the... How about the option of giving him the anticoagulation, rate control him for 4 weeks, and bring him without a TAE?
You can still do that.
You can still do that.
Still do that, although it does have a minor risk for stroke. I personally, just because stroke is horrible, and I've seen patients stroke, it's just a horrible thing to have. So personally, I've always thought the TEE is a very quick 10-minute thing. You just put it in TEE, make sure there's no clot, and then cardiovert.
So I guess the question, what is the risk of doing that 4 weeks anticoagulation, do it without a TEE? What's the risk of stroke?
The risk of stroke, as I recall, is less than 1%. So,
less than 1%?
Yes, but there is still a risk of stroke. However, there are variables to that. So the size of the atrium will decide it. So for example, you have somebody whose left atrial size is 6, and they tell you, oh, I started the AFib yesterday. And then you give them anticoagulation and they wait for 4 weeks. But it's not the same, because the velocity in the left atrial appendage, if it's very, very low, then there's higher propensity for stroke for clot formation. So there's a lot of variables, and in this, it's my personal opinion, is that we always just err on the side of safety and just a quick TEE or a CT angio. A CT angio is actually very helpful in looking at the left atrium, and we use it all the time. A quick CT scan, it can replace the TEE, and then you can see if there's no clot, just shock right away.
My last question, if you do a TEE and do DC shock, what's the risk of stroke? Is that
It's very, very minimal because there's a micro, this way because we are dealing with microemboli. And microemboli that you cannot see with the TEE are very, very rare. It's there, but it's very rare. So it's still safer when you look at it. It's much safer to kind of do a TEE with a shock and when you know that there's no clot, than just giving blindly 4 weeks of anticoagulation. I still think also that as I was saying, a CT angio is a very good way to do it. And if you have any kind of doubt about any kind of a clot, obviously don't do it. That's what I usually do. I wait 3 months and then I redo the TEE.
Any other question? Okay.
I just want to emphasize that the atrium is an important part of the myocardial function.
I'm sorry, can you repeat what you just said?
Okay, the atrial kick is, in
Yes.
some reports, it's like 30%
Absolutely,
of your cardiac
20%.
output. And if you have aortic stenosis, the atrial kick could go up to 50% of the cardiac output. So I agree that we should try to restore normal rhythm. 2 questions. How long would you, after you ablate, and ablation, one ablation is not really the answer. You could need more than one ablation, and the success rate will be additive. How long would you anticoagulate these people, and where do you see we are going with the artificial intelligence and monitoring these patients with the watches and all that stuff?
So how long we anticoagulate, all depending on the CHA2DS2-VASc. So it is imperative to anticoagulate for 1 month. You cannot anticoagulate less than 1 month, even if your CHA2DS2-VASc is 0. Because once you anticoagulate, we all remember from studying in medical school, the electrical resumption of activity, however, not a mechanical resumption. So the atrium may be in sinus rhythm, but it may be stunned and it's not moving yet. So it's based on the CHA2DS2-VASc after 1 month. So I would anticoagulate for 1 month, and if the CHA2DS2-VASc is 0, after I do the ablation, then we stop all medications, really. If the CHA2DS2-VASc is 1, it's reasonable to keep them on aspirin. But this is now, there's this trial where they're putting a watchman and doing the ablation at the same time to see if patients do better doing that. But this is in the US where the cost is not an issue anymore. Going back to the artificial intelligence in terms of fibrillation, obviously this is where we are all directed. The new AI integration might be in the 3-dimensional mapping of the system, where you can integrate the artificial intelligence to have more precise points where you can ablate. So this is probably going to be the future very soon, and we're probably going to have higher success rates in the future.
Dr. Munir has something to say.
No doubt, if somebody has heart failure and the heart failure is by AFib, then we have to be, of course, aggressive. But what do you think about, since you're only reached W, what about X, Y, Z with newer technology? Like there are newer technologies which potentially are safer and shorter time.
I'm sorry, with what?
Pulse field therapy, for example, potentially.
PFA, yes, PFA, hopefully.
So there are newer technologies which are potentially safer, yes, shorter time, and maybe even higher success rate.
Yeah, absolutely. So, I mean, there's all this newer technology that's emerging, and unfortunately, due to the time, we wouldn't be able to go over it all. So, these are based on the cases that I ablated in Jordan. Hopefully, once we have PFA in Jordan, PFA is this newer technology that is very safe in terms of pulmonary vein stenosis. So it's very selective to the cardiac tissue. So there were no cases of pulmonary vein stenosis. There were no cases of esophageal injury. And this is probably going to be integrated with RF in the future. The problem with that is that it lacks the 3D mapping. So it kind of gives you. Right now, I was actually reading that they're developing a catheter where it can work both as PFA, which is the newer technology, and the heat, which is the RF. Those are obviously very exciting, and hopefully we would have those in Jordan as well. Yep.
One more question, if there is one. Last one.
Thank you very much for this nice presentation, Doctor. What about the effect of ablation, electrophysiological ablation on the survival patient with AF, and does it increase the survival in all the cases or only in certain cases?
So in heart failure, it increases the survival for
Only-
sure. So Marouche and group, they
Only in heart failure?
in heart failure. Well, the other ones, it's not really a survival thing. It's more of a symptoms thing.
Yes.
So you don't want to get to the persistence stage, so that you don't. It's just going to make it worse. But in terms of strokes, it will increase the strokes if you stay in AFib. So sinus rhythm, there are studies that do show that sinus rhythm reduces strokes. In terms of heart failure, this is already established. So morbidity, obviously, is going to be completely affected, and we can extrapolate and say that this is mortality and is also survival is going to also be affected.
Okay, thank you.
Thank you very much.
نحن good time نحن ماشيين.